morning everyone. We all know about this Polytruma and we just quickly go through, 43-year-old female, mother of 2 kids, is a high velocity injury. Just imagine how important to know about mode of injury here. This is the message I want to inform you. So 43-year-old patient, full of people crowd outside the A&E. She is just lying in the stretcher. The take-home message in this point, how important the mode of injury is. And also, by assuming that mode of injury, how important to assess ourselves before seeing the patient. We may be at home, we may be at the part as a on-call room, but we can't just imagine it should be a normal injury, right? If it happens in the foreign country, the same incident, the story would be totally different. It means the same thing in advertisement, whoever the next of kin know, whoever the pedestrian, whoever called to the emergency line, ambulance will arrive to the place within seconds. The paramedics of that ambulance team, they will quickly assess the patient. At the scene, they will do whatever the needs which we are doing at the end. Stabilize the patient, heart column, spinal cord, IV access, pain management, if needed intubation. Everything is done. They do, I'll come to that point. They do everything properly and then call to the nearby hospital. There's an incident like this, there's a patient like this. We will arrive to your A&E in 7 minutes or 8 minutes or 17 minutes. Same scenario from that advertisement. So then what will happen from the hospital, immediately give the call. Everyone has not the hand phone. They have small bleep. Okay? Like a small walkie-talkie like gadget. Okay? Immediately come the voice note. There's a trauma code. That's it. If that call goes to the consultant, anesthetist consultant, on-call register anesthesia, surgeon, on-call surgeon, on-call register, on-call SHO, on-call HO, whole surgical team, and emergency A&E, imaging department, blood bank, immediately trauma code. Then what to do with the trauma code? All should go to the A&E within seconds and go and put the signature and time. They will assess at what time surgical SHO, surgical consultant came to this point after getting this call. Within minutes, seconds we should go. But we go there, we wait for the patient. Here other way around. Patient will come. Patient will wait for us. We will wait for the patient. We will wear the apron, label surgeon, label anesthetist, label emergency physicians, nurse, radiographer. Wear the apron. With the label, we have to wait here. Then patient will arrive with ambulance. So the paramedics, well-trained paramedics, will hand over the patient to the trauma team. Will hand over the patient. Okay, S-bar. Hand over the patient, right? They will tell age, incident, what happened, and what they have done at the scene, right? Right. So paramedics will hand over mechanism of injury, what are the injuries found, signs, treatment what they have given, they will tell. Okay, they intubated, morphine given dispatch, penicillin given dispatch, antibiotic on the spot. They do everything nicely. Okay, even far better than our hospital mode. Right? Right. Then that's it. Already we are there. And I'm telling why I'm telling is okay, how much we have to improve, how much we have to think and change. Right? The trauma team will be there, we are the team, and there will be trauma leader, it will be the on-call consultant, emergency physician on the A&E department, and he will take the role and quickly we have to around the patient, connect all the tubes and things and monitors and everything, and start the procedure. He will examine the patient. He will not write anything. Okay, he'll examine primary survey and he'll go through system by system. But another person nearby having a small chart with a tick box and write it down what she or he is telling. Understand? Right, I'll come back to this, our case. In our case, the patient will be brought by three-wheeler. Or maybe patient is waiting at the scene for half an hour or 45 minutes, and sometimes I don't know how the patient will come here, and after a while some car or van or most of them three-wheeler, right? Most of the three-wheeler in our center. Okay? So just imagine if a patient has had a head injury or C-spine injury or the lumbar spine injury, that's it. Three-wheeler, then there's no point of talking further, and they bring the patient here. No, we can't help. That's our country. And coming here, and we can't save the patient. Or the patient will go home with a disability, that's it. Right? So this is the patient. I went and saw the patient. I can still remember the incident. Okay, stretcher, thin small lady, high velocity injury. So you can feel both. If a patient with a huge patient with a tummy and things and all, we can imagine the less injury inside. Thin small lady with high velocity injury. Screaming, talking, screaming. Okay, pain. So he says of 15, talking now. I'll come to the point. He says 15, fine. And all the tubes and monitors and probes, everything is connected. Saturation okay, BP something, blah blah. Okay, so by looking at the patient, the left upper limb from shoulder to the wrist, no tissue, full of tissueless bleeding and tendons and muscles and everything is exposed, almost mangled limb. Okay, just expose the patient, there's a laceration in the face and skull bleeding a lot on one side and the stretcher full of blood. Okay, and abdomen, we can't touch the abdomen, full of abrasion in the abdomen. If you can have that photo, I can show you. Full of abrasion. We can't touch. We don't know the pain is due to that just abrasions and soft tissue in the abdominal wall or inside. Who knows? But we should always assume the injury is inside until proven otherwise. Right? Abrasion. And the one limb is just floating, tibial fracture, blah, blah, something like that. Pain, so maybe 9 out of 10. Airway is secured. I'll come to the point later. Patient is talking now, so airway is secured. So patient says, what has happened? I don't know, sir. I don't know what happened. That's it, that's enough now. And vitals are okay at that point. BP 100 by 10, heart rate 110, okay? And anyway, it's stable. He'll assume it's stable. So as usual, we started some fluids. Okay? As usual, we started some fluids. IV cannula, fluids, okay? And as usual, the fast scan is done. It shows minimal fluid, probably perisplenic injury. Okay, that's it. So now at the moment, airway secured. And A, I come to A. B, patient is talking, breathing part okay, circulation so okay by looking at this BP and pulse rate, right? So what is next? Blood transfusion initiated and patient stabilized. Why blood transfusion is initiated? There's a free fluid, heart rate 110. Now what to do? Do CT or to go operating theatre or IC. What we can do at this point? Now any part somewhat okay. Imagine that all the basic trauma series imaging, it means X-rays have taken. I will come to the point. I told you about our setup. What to do now? Patient stable now, somewhat stable. Okay, what to do? Go to CT or OT or ICU? CT. Yes, ideally CT. Stable, free fluid, ideally CT. Okay, but and also patient, the heart rate was fluctuating ups and down now. BP slightly started to drop. Now what? What to do? OT, CT, ICU. Huh? OT, right. We can consider OT when if the resuscitation fails. It means if we are giving fluid challenges, still on top of fluid challenge, patient's BP and heart rate is deranging. Keep on deranging. Or if you are giving the blood, still BP is dropping, heart rate is going up. In that point, yes, no point of further giving, we have to do something, right? So at that point, theatre, doing everything and going to theatre. Here, with the fluid responding, not responding, okay, something like that. So, if the patient ICU for the resuscitation, blood and blood products, and repeat all the investigations. The night time, right? And repeat the fast scan again. Right, fine. Now patient somewhat okay, but hemoglobin starts to drop. Then we did the CT. CT short, screen is perfectly alright. Free fluid, now minimal free fluid became moderate free fluid. And the hemoglobin dropped from 1340 to 7, patient stable. And very little injury. Now what to do? Keep on, yes, escape the ICU and hemoglobin dropped and CT tell you injury. Now what to do? Keep on monitoring, keep on resuscitating the ICU, or do some intervention. Young lady, what to do? Same patient. There are 4 options here. Anyway, we plan to go for an intervention. Mangled, almost mangled limb, tibial fracture, facial laceration here and there, and suspected some abdominal solid organ injury. What to do? 4 options. Laparotomy with fixing tibial fracture, laparotomy with definitive surgery for upper limb tissue loss, monitor further with repeat investigations, laparotomy alone. What is the option here? Laparotomy alone. Forget about the tibia, forget about the upper limb, forget about the laceration here and there. Why? Here, life or limb. Life or limb. First we will stabilize the patient, make the life. Then we can do the tibial fracture, the tendon repairs and skin grafting, maybe weeks after a month later. But here, first thing we have to stabilize the patient and make the patient's life, ensure the patient's life. Understand? So laparotomy alone and then feel the liver injury and manage and patient ultimately everything is done and 3 weeks to 1 or 2 weeks in the ICU and then patient was okay. And for the upper limb tissue cover we sent the patient plastics and they had done a great job and the patient went home nicely and I think patient came to meet me and maybe 2 weeks, 3 weeks also later.